Welcome to the Doc Talks podcast. I'm your host, Mandy Fields. I'm here to ask medical experts the questions you might have about diseases and conditions, from heart health to dementia and everything in between. Join me for a conversation where we get right to the points you need to know to navigate Canadian medicine and hospital healthcare. Hi, I'm Mandy Fields, and welcome to the Doc Talks podcast brought to you by St. Joseph's Healthcare London. On today's episode, we are talking about the most common type of cancer, skin cancer. In Canada, 1 in 3 cancer diagnoses are skin cancer, yet it is mainly preventable. I'm here with head and neck surgeon Dr. Corey Moore, Chief of Facial Plastic Surgery at St. Joseph's Healthcare London, and Associate Professor in the Department of Otolaryngology, Head and Neck Surgery at Western University. Dr. Moore specializes in facial skin cancer and reconstruction, facial trauma, and facial cosmetic surgery. Thank you for joining us, Dr. Moore.
You're welcome. It's a pleasure to be here.
So, Dr. Moore, tell us a little bit about your background, your education, and what led you to your work here.
Well, I love St. Joseph's Hospital. I was born in Winnipeg, Manitoba, and I came to London for a residency in head and neck surgery, otolaryngology. And, both my kids were born here. They were actually born here at St. Joseph's Hospital. But I completed my training here, and I always had an interest in plastic surgery. And so I was going to do further training in plastic surgery of the face, head, and neck. And it just so happened that Wally Stavraki, who was the head and neck plastic surgeon here at St. Joseph's Hospital, was retiring. And that was just when I was ending my training. So the chair of our department said, if you're going to do plastic surgery training, then would you consider coming back? And I was just thrilled. I thought I was just going to go back to Winnipeg and get a job. And I was very naive because it doesn't work that way. You have to put as much effort into getting a job as you do in your training. And that goes for any sort of profession and job. And I was just naive. I thought, well, I have all this training. They'll just hire me. And I just got lucky. And so it was perfect because my wife, again, was from Winnipeg. And as I said, both our boys were born in London and she loved London. And so it was just luck as it had it. And the rest is history. We, in southwestern Ontario, again, like Winnipeg, surrounded by farm community and people exposed to the sun, obviously in the summertime, lots of sunlight hours in North America. And if you have lighter skin, it does take a toll. And so it is if you're kind of looking for a specialty, being interested in skin cancer, southwestern Ontario is really a hotspot. North America really is. And I've been busy doing that ever since. I performed just general facial plastic surgery and reconstruction for the first 10 years of my practice, including skin cancer. So that included facial trauma, scars, deformities from congenital issues. But the cancer practice in the last 10 years, and I've been here about 23, 24 years, has grown so much. I was pushing most of my non-cancer surgeries way into the future. And I just decided at one point that it wasn't good patient care to do that. And so I do exclusively skin cancer now in my practice for about the last 12 or 13 years.
Oh, wow. So when you're standing at Costco, when you see like Joe Public, do you ever set your eyes on and you can tell if something's skin cancer?
Yeah, a lot of times you can. And I think that sometimes it can be less obvious. And that's the insidious thing about some of the cancers. And of course, there are a lot of different cells in the skin, and each one of them can turn into a cancer. So some of them look different than others. Some of them are more dangerous than others. And if I ever do see something obvious, I have gone up to people that I don't know. And you have to be careful. But I often mention that I'm a physician, and I'm a little concerned with what I see. And people are usually very appreciative of that. And most of the time they are having it looked at.
That's good. I can't imagine saying no. If you approached me and you said, hey, lady, there's something suspicious on your neck there.
Yeah, everybody's different, right? It's one of those things. I do occasionally take a couple second looks, discreetly, of course, because you don't want to have your eyes stare too long. But if it is an obvious cancer, then I certainly would go up and talk to them in just a concerned way.
Right. So you mentioned right at the beginning how southwestern Ontario is a hotspot for skin cancer. Can you talk a little bit about what the causes of skin cancer are?
Yeah, so I think this is pretty well proven as far as rays of light that come down from the sun. You have 3 of them. UV radiation. They're based on wavelength. Just like visible light and laser and all sorts of different types of X-rays, they're all an electromagnetic spectrum of photons. And photons are particles of light that have a specific sort of wavelength. So the three photon wavelengths that come down from the sun are UVA, B, and C. A is our standard sort of sun tanning bed light. The interesting thing about UVA is it goes right through glass. And so, if you're in your car and you don't have UV glass, which most cars don't, it'll go right through the glass and you can get a tan through glass. B is the bad one. So you remember B for bad, and that's the way a lot of people remember it. B causes DNA damage to your skin cells. It's a direct cause for DNA damage, which can cause cancer. Most times it causes just sun damage, like there's a precancer called actinic keratosis, which you see red spots that are flaky, and those are precancers, but majority of those never turn into cancer. They oftentimes just disappear with time. And then C is like UVA, is very similar wavelength. It doesn't tend to reach the Earth's surface, and so people that are out and about in the sun don't usually get UVC. So there you get UVA and B. And so the research is very good in the sense that UVB does cause DNA damage and is a direct relation to skin cancer. A, the sun tanning beds, there has been recent evidence that links it to melanoma. It's never really had the attention of UVB though. And, only in 2010, I think sunscreens started protecting against UVA. It was always protected for UVB, but UVA, it's more of a physical block. So the problem with UVA protection, it's like titanium oxide, zinc oxide. They're almost like wearing t-shirts on your skin. And the problem with that is they tend to make you look very shiny and greasy. And so people don't like them. Over the last 10 years, the sunscreen companies, skincare companies have made a lot of progress in UVA coverage, and they've micronized the zinc. And so it's less greasy and it's much more comfortable. It's pretty hard now to get a sunscreen that doesn't cover against UVA and B together. And that's mostly because of the research that was done about 10 years ago, where they showed that UVA doesn't directly cause skin cancer, but it makes UVB more adaptable to causing cancer. So it helps UVB cause cancer. And so it's a good idea to protect against both. It's always been known that UVA creates sunspots. So, liver spots that people talk about, freckles, can cause premature aging of the skin, wrinkles. And so it was always kind of say, well, UVA, it's kind of like it's an aging sort of ray of light. It doesn't really cause directly skin cancer, but that research has changed. And so I think that the companies are paying attention. And as I said, for sunscreen. So to answer your question, it's the sun that causes skin cancer. And I guess to further that, it's the sun's interaction with particular types of skin types. So you and I are light-skinned individuals with light eyes. That indicates that we have cells in our skin called melanocytes that produce melanin. That's like the black paint, I suppose. And it's very similar to the fact that if you think about it, in the summertime, if you touch a black car, well, you burn your hand. It's because that black paint and darker paint is holding on to the UV radiation from the sun. A beige or white car, you can put your hands all over it, no burn. And so the similar way to think about it for skin is that you have these melanocytes, and we don't have as many melanocytes, those people with light skin, and so less melanin in the skin. And so when UVB comes down from the sun, it actually transmits into your skin. So people don't realize this, but it actually goes into the skin, and it can bounce around on your DNA like a pinball and create damage. If somebody has a lot of melanosomes, these are little things that come out from the little tentacles that come out from the melanocytes and produce pigment, well, then that pigment grabs onto that UV radiation and prevents the pinball effect of the DNA getting damaged from the UV. And so it's the characteristic of having light skin, light eyes, indicating that that person doesn't have a lot of melanin. That's that pigment that grabs onto the UV radiation and allows the UV radiation to damage the skin cells.
Wow. I honestly don't think I'm smart enough to fully understand it. And I don't mean that flippantly. I mean, I understand sunburns, but my own lived experience in our family. And I'm wondering about this. So my mother-in-law in 1994, she lost her life to melanoma. And when her cancer diagnosis was revealed to the family, I think we, at first, because it was skin cancer, it was almost, we were afraid, but it didn't feel like the death sentence at, say, breast cancer or lung cancer. So my question is around, so 1994 is when she lost her life after 18 months battling, which is melanoma cancer. Has there been a lot of changes? If she was diagnosed today, are you able to speak to that?
Yeah, so I'm sorry for your loss. That must have been, she sounds like she was probably quite a young woman back in those days, and that's the tragedy with melanoma. Melanoma's incidence has gone up tremendously from 1 in 1,200 in 1900 to today, if you're a woman, 1 in 34, and then in males, I think it's 1 in 31 in Canada. So the incidence, it's hard to know because a lot of times back in 1900, the diagnostic abilities of physicians, and there's the fact that people didn't go to a lot of doctors back then. Maybe perhaps they had melanoma and it wasn't diagnosed, and it wasn't until that they died of it that they may have made the diagnosis. But either way, I think the incidence has gone up. I mean, I just think of my grandfather, who was a farmer in southwest Manitoba, and I never saw him without a plaid shirt and hats that covered his whole head. So he never had a sunburn ever. And I see farmers nowadays, married to some of the nurses I work with, and they're out in the fields with bare backs and getting burnt. And this is in 2024, last summer. And so I think the attitude has certainly changed over the many years as far as sun exposure goes. With respect to your mother-in-law, melanoma, unfortunately, is a little bit of a different cancer than the other skin cancers. Most skin cancers, and we call skin cells, standard skin cells in the skin, keratinocytes, and they're the most numerous. They're the ones that are shed off as you exfoliate. Those primarily turn into basal cell and squamous cell cancers. Those cancers are staged by size. So squamous cell in particular has to get fairly large before it metastasizes. Because let's face it, if the cancer just stayed in the skin, it wouldn't be a big deal. We have lots of skin, we can treat that. But if the cancer spreads to tissues like the brain tissue, the liver tissue, the lung tissue, you don't have a lot of that tissue. Melanoma is not staged by size, it's staged by depth of invasion. And so a melanoma can be very, very small, yet invade very deeply, and it can be a very high stage. And so what can happen is a person like your mother-in-law perhaps maybe had a little mole on her back, and it stayed there for many years, not changing much in size, but just going very deep. And once it gets past a certain depth, melanoma is a beggar. It will kind of metastasize. And so it's different than the other cancers, which is quite scary in a lot of patients, right? Because I mean, I may have a mole on my back that's been there for years, and you may not know it's melanoma until it starts bleeding or ulcerating. And so it is hard sometimes for diagnosis. Now, when melanoma stays in the skin, it can be very treatable. And in fact, people don't realize this, but melanoma skin cancer is one of the most curable cancers in the world if you catch it early. The cure rates for stage 1 melanoma, that means it's isolated to the skin, not spread anywhere else, and of a certain depth, is 96%. I mean, that's almost like 100% in non-medical talk, because we can never say anything's 100% in medicine. But 96% is pretty darn high. And that's with just surgical excision. That's no other treatment. Now, if we talk about melanomas that are higher stage, that metastasize, like your mother-in-law, to other organs, there's been actually quite a big improvement in the treatment of those patients. There's a treatment called immunotherapy. One of the things with melanoma is the melanoma cancers are very immunogenic, means the immune system attacks them. They have antigens, they have protein grows out of the cells that actually attract the body's immune system. So smart doctors, scientists have taken advantage of this and created medicines that stimulate the body's immune system better to attack these cancers. And so I have patients who were diagnosed in 2010 with distant metastatic melanoma to liver, and they're still alive 15 years later because of the advances in immunotherapy. So you would never see that back in 1994. So to answer your question, yes, there has been a lot of major advances. Not so much For the early stage melanomas, that is still the same. Surgery, surgery, surgery is always for cure, but it's more for the well-advanced cancers where those patients were lasting maybe 3 to 6 months. Now they're living for 15 years and more. So it's quite amazing and quite exciting to be around and helping those patients, because we do see distant metastasis in melanoma just for the very reason I talk about. They can be very small in size, but very deeply invasive.
And that was the situation with Mavis. They just kept on cutting it out. It was almost like just parts of her body just kept on being cut out on where it started. For our listeners, can you share with us what are the signs and symptoms that we could be looking at of skin cancer that we should be watching for?
Yeah, so I always talk to my patients about having a new sore that's maybe present more than, 12 weeks, 8 weeks. We all get pimples and things of our skin and little cysts and growths, and you pick at them and they bleed and things like that. So if we take a step back and we say, well, if we look at moles, for instance, like a standard mole, and we all have them. The interesting thing about moles is you're born with all the moles you'll ever have. They just don't start growing to certain ages. And so when you hit into your teenage years, you actually start growing a lot of moles, and they're called junctional nevi. It has to do with where the mole cells are in the skin, and these are moles that are in between the epidermis and the dermis. And they actually change quite frequently. And I get a lot of calls from mothers saying, I have a teenage son that's, 15, and he's had a mole and it's changed in the last month. It's changed color. That is actually pretty standard for certain aged moles. So you have, young moles, teenager moles, and then the older adult moles. Junctional nevi can change. And if it's a junctional nevus in a teenager, you do see that. That would be very abnormal for a 40-year-old person to have that. And so typically all the moles that you're born with show themselves by the age of 40. It's very rare for somebody to get a new mole after 40. Most times they're not moles. They're things like seborrheic keratoses, which were very common skin growth. So they're other things. But if you get a new lesion and things like pain, itchiness, bleeding, of course, is a bad one. But if you're picking at it and it bleeds, that's kind of common. Typically, these little things disappear. Keratoses are a common thing that we see that people mistaken for melanoma. They're brown spots. The old surgical textbooks used to call them barnacles of aging, but I've had one on my leg since I was 20, and I didn't think I was necessarily old back then, but you do get these recurrent ones. They do tend to grow a little bit faster. Skin cancers, oftentimes, most of them apply that ugly duckling syndrome that we talk about. This one doesn't look like the other ones. I have this thing on my hand and it doesn't look like the other one. That's sometimes enough to maybe ask a doctor to take a look at it. One of the things that and I think a lot of more family doctors are interested in skin now, but to have full skin exams, if they can get into a family doctor and have a family doctor and just have a look and make sure, the back looks okay, and true moles, and if they are changing, they can change, but it's a timing thing. So if you have a mole and you're not 15, and you have a mole and you're 45 or 35 and it's changing, it looks different at 2 months, well, you should probably have that looked at. The other thing is size. So skin lesions that are of a certain size. And for melanoma brown spots, we usually use 6 millimeters in greatest dimension. There are other things. We have an ABCD system in medicine that we talk about, and it goes through, size, diameter. Irregularity is if you split the mole down the center, is it the same on one side versus the other, or is it different? These are all little things that we look at and monitor. With patients, though, I would say the biggest sort of factor that you should pay attention to is the rate of growth.
Okay. Is there a certain body type that is more common to have skin cancer?
Absolutely. So body type and the skin coloring. So, again, in medicine, we have a Fitzpatrick scale, and dermatologists use this to sort of communicate skin types for documentation purposes as well as just monitoring. But it speaks to the sensitivity of the sun to the skin. So Fitzpatrick 1, those are patients that always burn, they never tan. Fitzpatrick 2, mostly burn, some tan. Fitzpatrick 3, tan, some burn. 4, never really burn. They mostly tan. Your ability to tan and not burn really is a kind of a one indicator with respect to your sensitivity to the sun and skin cancer. But generally, the lighter the skin and the more ability to burn, because what a burn essentially is is damage to your skin and the inflammation that's resulting from that. Okay. And so if somebody has a lot of melanin, that black paint in the skin, or the darker paint, you're going to be able to absorb a lot of that UV radiation and not have your normal cells damaged. And so you're not going to burn. Versus, say, somebody like yourself, if you laid out without sunscreen, you're going to get a pretty bad burn because that UV radiation, that UVB, is going to go into your skin and cause damage. Nothing's there to hold on to it.
And what about body parts? Do you see a more common body part that shows up?
Yeah, like the face, head and neck, and the hands are the most common because if you think about it, these are areas that are always exposed to the environment and always exposed to UV radiation. So even when you're driving your car, your hand's usually on the top of the steering wheel. You tend to get a lot of sunspots in those areas and the face. And then, of course, I grew up in the 80s. And it was very common for people to mow their grass in halter tops or no shirt for men and the shorts. And so again, those types of sun exposures for prolonged periods aren't the greatest.
So I can't resist. Have you ever seen it on someone's buttocks? I had to ask.
No, I've seen sarcomas, which are different types of cancers on buttocks, but I've never actually, well, I shouldn't say that. I have seen it on the buttocks in areas that are more private for sure. My specialty is head and neck, but skin cancers don't usually come in singles, right? I treat a lot of skin cancer of the face, head and neck. And if somebody comes in with a cancer in their eyelid, if they want me to look at another place, we certainly will do that. And we will treat it if it's an appropriate cancer. There are certain cancers that we have to refer to specialists of that area just because of the risk of metastasis. But certainly I've checked all body parts, and certainly I don't think there is one that I haven't seen a skin cancer.
Thank you for humoring me. Is there a difference between mineral sunscreens or chemical sunscreens, or do you just recommend people just use any sunscreen?
So there are different types of sunscreens. There are the physical blockers that actually are basically like wearing a t-shirt on your skin. They work by physically blocking the sun, reflecting it, right? And so those tend to be the things that have zinc in them, zinc, titanium oxide, zinc dioxide, things like that. And in the past, those were very, very shiny. They made your skin almost look white. People hated them. I think that's why my wife hates sunscreens to this day, because she tried those back in the day and they make you look sweaty. And so they've improved that technology a lot. And then there's the chemical sunscreens, the binding sunscreens that actually bind with your skin cells. And so those are kind of a little bit different. I tell people, don't break your bank. You can buy sunscreens for $120 and plus. Personally, I just go to Superstore or Shoppers and I buy oil of Olay. I'm not endorsing them, but I just use it because it reacts nicely with my skin. Oil of Olay Complete Defense. Think of football, Complete Defense. And I buy the 30 and it's for face. And it just, with my skin, it doesn't make me look greasy. It doesn't clog my pores. Now, I could recommend that to Mandy and she may put it on and it may give her pimples, block her pores, and do all sorts of things. So everybody's skin biochemistry is a little bit different. And so I would say, number one, you may want to get your sunscreen from a reputable, like a Shoppers or something. And oftentimes endorsement by American Dermatologic Association, it's not required, but I think the key thing is on the bottle, they should say UVA and B protection. And again, whether you get 30, 60, whatever, it really just, all that indicates is, the timing, how often you should apply it. I think, anything is probably good. I use a 30 and anything above 30, I suppose you could use, but it does seem to be a little bit of a thicker sunscreen the higher protection you go. So the mineral sunscreens, I think they're probably just as good as the others. Again, I tend to stay away from compounding pharmacies that make their own sunscreen. I just don't know how much testing has been done on that. But again, it may be okay. It's hard to know without seeing the ingredients in the list. If it doesn't say any ingredients on the bottle, I think that would be cause for concern. A lot of the sunscreen ingredients are so long there. The names are, you almost have to have a PhD in chemistry to actually pronounce them. But some of the well-known brands, Oil of Olay and things like that, I think they're just fine.
There's a trend right now with people using LED masks. Does this contribute to an increase in skin cancer?
No, it's a different wavelength. So electromagnetic spectra, it's a very, very long sort of spread out spectra. So there are microwaves on there are X-rays, there are LEDs, there are laser energies, and so many of these are harmless. I can't say that the LED is doing anything at all, but maybe it makes people feel better. And you know what, quite honestly, sometimes that's a great thing. If it makes you feel good and it's not doing any harm, why the heck not, right? As long as it's not breaking your bank account. But, as physicians, we really have to, when we recommend and talk about things, we really have to have good hard evidence to recommend something like that, or say this is not good for you, because occasionally it's not good for you. But the LED thing, I think, is probably okay.
Let's just shift gears a little bit and talk about skin cancer treatment. So, what is some treatments and what kind of outcomes, if I'm diagnosed, could I expect as a patient?
So it really just depends on the type of cancer. So let's talk about the most common type of skin cancer, the skin cancer of the keratinocytes, the normal skin cells, the most populated skin cells of the body. Those are the ones that are shed, and when you're looking at the skin, those are the ones that you see. So the most common human cancer in the world is basal cell cancer. That is the most common skin cancer, and it's the most common human cancer. Those are, it depends, and because there's, with each type of cancer, basal cell cancer, squamous cell, and this, they're all certainly related with the exception of melanoma. It has to do where they develop in the skin itself. So for clinical subtypes, the most common types are the nodular variety. And so typically they are treated very well with surgical excision, depending on the size, the location, what reconstructive techniques you need. Radiation can be used with equal treatment outcomes. But again, when you see a physician with respect to your skin cancer, they will kind of say, well, what would be the best for the patient? So, I always kind of use the example, well, if you have a skin cancer of your ear and it's quite extensive, if I have to remove most of the ear and do a reconstruction, well, maybe radiation would be better because they can preserve the ear with the same cure rates versus, say, a small cancer on your cheek, again, easily treated in the clinic, without the extensive treatment with radiation. That would be better treated with surgery. But it really does vary. Those are sort of the kind of more solid forms. Many of the skin cancers that we treat are more superficial, so they're not going deeper into the skin. A lot of times you can use more superficial treatment. Liquid nitrogen occasionally. There's a treatment called photodynamic therapy where we use a special type of cream that has an amino acid in it called aminolevulinic acid. And all cells take up this amino acid, but cancer cells and precancer cells have a very hard time metabolizing it. So what happens is it selects the abnormal cells out from the normal cells, and you get a buildup of a byproduct because those cells, those cancer cells, can't use it. So that's a very effective treatment for oncology because it's selecting the cancer cells versus the non-cancer cells. And that's always a struggle in cancer therapy because if you think about surgery, radiation, we're always damaging normal cells as well. If we incise or excise a cancer, I will always have to take normal cells with me. With radiation, you always have to treat a margin. So this is taking more than the actual cancer and you're damaging normal cells. With photodynamic therapy, it's selecting only the cancer cells. And so they build up this byproduct after about 2 hours of applying the cream. And then that byproduct is very sensitive to red light. And so when they shine a red light on these cells, it causes what we call a photochemical reaction. The red light initiates a reaction with the aminolevulinic byproduct, and it kills the cancer cells. That's a very, very effective treatment. And I also work at the cancer center. We used to have a photodynamic therapy program. I used to run a clinic there with a radiation oncologist, but unfortunately, due to a variety of reasons, it was closed down. And I was so sad when that happened because it was such a great treatment for those patients that didn't necessarily need excision or radiation, but they were in between. You can still get photodynamic therapy now, but usually they're in private clinics, dermatology clinics, and unfortunately you have to pay money. Now, some insurance plans will cover it as well, so that's a benefit. But I wish we could bring it back to the cancer center because it was just such a great treatment, and the clinics ran all the time.
I know people can't see your face, but I can tell just by the look on your face and the way you changed talking about it, that must have been a really great treatment because you look
Oh
really
yeah, no, it was
excited.
great. Yeah.
Can you share with us, though, what detection services and what treatments are available at St. Joseph's right now?
Yeah, with respect to patients with cancer are followed by often surgeons like myself. And so we do monitor patients that come in and certainly there are, like I mentioned, patients that come in oftentimes have many cancers. They'll come in for one, but they have three other ones that aren't diagnosed. And so oftentimes they become part of a practice. And I myself and others, Dr. Kathy Roth here at St. Joseph's Hospital and others that treat skin cancer will follow those patients. And, we're always on the lookout, like your question about the people at Costco. We're always on the lookout for little things. And oftentimes when patients come in, and this is probably true with all physicians, you may see their loved one there with something on their skin and you ask about it. And I collect a lot of patients that way, new patients, just by loved ones coming in and I see something on them and it turns out to be skin cancer. It's very, very common.
I've got a few more questions here that I'd like to ask you. And I'd also like to invite you if you want to share something with me, of course, but with the listeners. But you mentioned you have two sons. So when your guys go out in the sun, do you lather them up? What do you do when they go out to play?
Well, I'm quite embarrassed. And I'm sure this is the general public, right? I have one son that takes after my wife, and my wife has blonde hair and blue eyes, but she has olive skin and she's never burned. She never burns. And she doesn't wear sunscreen, believe it or not. I'm embarrassed to say that, but she does not wear sunscreen until now we're both in our 50s now. She started developing sunspots and she doesn't like that. So she started wearing a little bit on her face. My one son takes after my wife. He doesn't burn, so he just doesn't wear sunscreen. My other son is like me. He gets red very easily. And so he wears sunscreen religiously because if he doesn't, he gets blistered. My sons are probably as old as you are, so I think that you can't really tell them too much. You tell them one thing, they want to do another thing. But I think it really has to do with the person and their experience. So it's unpleasant getting a sunburn. We all did it. I mean, I did it. I remember sitting in my basement when I was a kid, freezing the first day of summer because I'm shivering because I'm so burnt. And then you get that first burn and out of the way, and then you seem to be okay for the rest of the summer. But it is unpleasant. And so I think it really has to do with the individual and their experience with the sun. I think that when you're young, you don't think of wrinkles, you don't think of skin cancer. And so you just have to go to Grand Bend or Port Stanley and you're seeing young people, middle-aged people, older people just getting toasted out there without any sunscreen. And you'd swear the only thing that's different is the clothing, like the bathing suits. It's like 1970 all over again out there.
And do
So
you find that mind-boggling? I mean, we know that there's been a lot of public service announcements out about the sun.
not really. I mean, we're all human, right? And I think that certainly if you have a personal experience with somebody with skin cancer like yourself, you're going to be very aware of that. But most young people have no experience with medicine and, their parents oftentimes are healthy, no skin cancer. And so it's something you just don't think about. We all enjoy being outside, having the sun hit our skin, and it feels good. I mean, there are hormones released when that happens that are happy hormones. They make you feel good. And I always tell people the same thing, even with my skin cancer patients, because life is short and we always want to do things that kind of keep us on this world a little bit longer. But you also have to enjoy your life too. And I just say, if you like chocolate cake, have some chocolate cake once in a while, but you just don't want to overdo it. I met a nun that was here many, many years ago, and she gave me a great piece of advice similar to what I just said. It was funny because she used to live in my old office on 900 Richmond. She used to live in the nursing residence. That's where our offices were. And it was a long hallway. She had her little room with the nurses lined on both sides. And she came in because she had a skin cancer in her nose. She was like 95. And I took it off and she says, Dr. Moore, I used to live in your room. I used to live here. And I said, really? And that hallway is still there. There's a fire escape that goes down a window. And she says, you know why I lived on the end? And I said, why? And she goes, well, I used to have a yardstick here. And she said, every once in a while, the nurses, their boyfriends would try to climb the fire escape. And they'd have their hands on the window. I wrapped their hands. I go, really? And I said, did they fall? She said, some of them, but they were young. They could take it. I thought it was so funny. But I said, and I say this to all my patients that are in their 90s and 100s. I said, do you have any secrets for me? I won't tell anybody, but do you have any longevity secrets? And she says, Dr. Moore, I do everything that I love to do. I don't spare anything. I enjoy my life. But I said, I don't overdo anything. And I thought that was a great piece of advice. It applies to eating chocolate cake. It applies to sun exposure. A little bit is okay. A lot is probably not the best. As humans, we're made to be in the middle. Anything extreme, I think you're taking a bit of a risk. And sometimes that risk is worth it, right? Because life, as I mentioned, life is short. If you're into long distance marathon running, I think there's pretty well good studies to show that shortens your life if you do too many of them. But if you do it once in a while and you love it, well, then do it.
Well, it feeds your soul in a way that other things can't.
Absolutely.
You're right. One of my final questions is, if people do seek treatment and there's delays from seeking the treatment, like what can I expect if I have to reach out? What's the actual pathway to treatment to get to you?
So I always say the Canadian healthcare system is the best in the world. It is excellent if you need urgent treatment. We get the best treatment in the world, but there are wait lists and whatnot. However, with every physician's practice, we do triage, and I triage, and most of my colleagues triage referral. And we do this every day. I sit down and I look at the referrals, and if something needs to be seen urgently, they're seen tomorrow. So if something is delayed, so if somebody has something and they come in and they need treatment tomorrow, they get treated tomorrow. They get treated today if they need it. I think where people are a little bit kind of, they compare themselves to the United States. If you have like a basal cell cancer that is no risk of really metastasizing, it's been there for a couple years. It may have started bleeding recently, which is very inconvenient. But we do know that they grow very slowly. A lot of times people will have to wait months for those, depending on the location. I think that with Canadian healthcare, in the sense that the decisions made would never put you at risk, your life at risk, in all the physicians' offices I know. So I think that if you do get an appointment that's 3 months down the line, I think that if you're concerned, certainly call the physician's office and ask. But I think if you need care, like for instance, we just had 3 referrals for melanomas over the last evening. I reviewed them today. They're being seen tomorrow because they need to be seen urgently. But the occasional patient may have to wait. It's because of the urgency thing. So triage is important, but I think that people do have to realize that when they do see their physician, they will be seen in an appropriate period of time, not to put them at risk. That's an important thing to say, because I think people sometimes worry that they're being left behind, and I think the decisions made are in their best interest. Of course, we'd like to see them tomorrow, but oftentimes decisions are made to get the most urgent patients done quickly.
I appreciate how you said that it's an important thing to say, because I think it's a really important thing for us to hear when you're not inside the health world, getting us better, healthy. Dr. Moore, my final question. Are there any new and exciting findings or treatments on the cutting edge of skin cancer research right now happening at St. Joseph's?
We are always innovating. We have the fortunate pleasure and privilege to be associated with Lawson, and I personally can just speak for myself. I work in the engineering department with an engineering doctor. His name is Luis Ferreira, and we are making huge strides right now in not so much treating the actual cancer itself, but the post defects of cancer. And so just to give you an example, do fairly large cancers that often require removing someone's full ear, their full nose, their eyelid, their cheekbone. And these are tremendous defects that are catastrophic for a lot of patients. Now, we oftentimes do the reconstruction at the same time as the oncologic ablation, the cancer removal. These are long cases and oftentimes require taking bits of skull to reconstruct cheekbones, bits of rib to reconstruct noses, all sorts of things. Right now, we're doing research in using a robot to do a lot of the milling of these new body parts. So to give you an example, our recent research for myself to harvest a piece of rib cartilage, and then I do the manual carving to make a new ear, for instance. To carve an ear, and this is just me kind of looking at the other ear and trying to match it, takes me approximately an hour and 20 minutes. We have technology now that uses a robot where we actually do a 3D scan of the other ear. It feeds it into a computer that goes into the robot. The robot can trim and make a new ear out of rib cartilage in less than a minute And it is so much better than what I can do freehand. It's amazing. And so this is just some of the technology. We've used this technology now for nose reconstruction, for cheekbone reconstruction, and auricular reconstruction. So it's just great research, and we've had very fortunate, generous donors giving towards this research, previous skin cancer patients. And it's been just fantastic.
That would be life-changing.
Yeah, it is.
Would be.
And, it's so much better for patient care in the sense that it saves like at least an hour of OR time. And if the defect is bigger, probably more, less anesthesia time and better results. So.
Do you feel like what a win? Like when you see that happen and you help somebody, like it's just, what is that feeling like? What is that?
Great. I love the translational research going from the bench top with the scientist, Dr. Ferreira, and the engineers to bring it to the OR. It's just wonderful. And patients are very appreciative of it as well. Now you get the occasional old fella that, we take their ear off and they actually just want to keep it that way because it's a good conversational piece when he goes to the cafe for coffee. Sometimes I have to, you're going to have a robot carve my ear? No, thanks, Dr. Moore. I'll just keep it the way it is. But I think time will progress and people will catch on that it's a good thing.
Well, thank you for joining us today, Dr. Moore.
Oh, you're welcome.
That's it for this episode of Doc Talks podcast. If you're interested in learning more about skin cancer prevention and treatment, visit St. Joseph's website at sjhc.london.on.ca. Join us for our next episode of Doc Talks and be sure to follow us on Facebook, Instagram, and Twitter at St. Joseph's London. Until then, stay healthy. That's it for this episode of the Doc Talks podcast. Thanks for listening, and join us next time when we'll continue our conversation on what's new and relevant in the world of Canadian medicine and hospital healthcare. Join us for our next episode of Doc Talks, and be sure to follow us on Facebook, Instagram, and LinkedIn. Until then, stay healthy.